Hi, my name is Clayton Eckerd, and today I will be discussing the topic of meaningful use and performance measures. So first, I'd like to just right here talk about some acronyms. I put them here for your convenience. I will actually go through and discuss the majority of these, but they are used. They're used throughout a lot of the data that I went and researched, and they are just here, like I said, for your convenience. If you need to go back and check out one of these and what they mean. So the first thing I'd like to talk about is performance measures. So the Health Resources and Service Administration defines it as the regular collection of data to assess whether the correct processes are being performed and desired results are being achieved. So there are financial versus non-financial performance measures. Example of a financial performance measure would be a paper performance. So this is where a company would ask that their employees carry out a certain task, and if they do, they would receive some type of financial incentive. It's pretty self-explanatory in the name. And then there's also non-financial performance measures. So I found an article conducted by Bailu, Heitger, and Tebor about East Alabama Medical Center. And they actually have certain goals for tracking non-financial performance measures, such as maintaining and improving the quality of the clinical services, improving patient service, enhancing employee recruitment and retention, and then maintaining accreditation. So that's the goals that they have. And then they also have some examples of non-financial measures that they had given. So, for example, issues related to medical supplies, such as the number of inventory turns or the bed supply or the occupancy rate. So, how often they have patients occupying, a bed, and then also the staff supply and availability. These are just a couple of examples of non-financial measures that companies may also utilize for performance measures. But also, as you will see, this is probably the only thing I will say about performance measures. It kind of ties into this next topic, which I think is the bigger topic to discuss, which is meaningful use. So, meaningful use deals with the process of using certified EHR technology. EHR stands for electronic health records technology, and using it to improve quality, safety, efficiency, and reduce health disparities in the healthcare field. That is the definition that was given from the CMS website, which is Centers for Medicare and Medicaid Services. So basically, meaningful use was put into act whenever the HITECH Act of 2009 came out. What this program did is a governmental program and include billions of dollars in incentives through Medicare and Medicaid to promote meaningful use. So just to get companies to convert from using manual reporting methods to placing into electronic system in hopes of improving overall quality of care. So the EHR incentive program actually consists of three stages, which we will go into for the next slide right here. However, I'd also like to discuss that the stages differ depending on whether they're talking about eligible providers or eligible hospitals and critical access hospitals. So first I want to talk about eligible providers and their stages. Eligible providers, as you can see out here, I have a list: physicians, physician's assistants, and then doctors of medicine, dental surgery, optometry, and the like. And so eligible providers for stage one have to meet a decent amount of criteria. So they have to meet 13 required core objectives, 5 objectives from a list of 10, and 6 clinical quality measures. Now I know right now you're thinking, okay, what does that mean? I will go into detail right now. I just want to give a brief overview of what they must do. And then for stage two, it bumps up to 17 core objectives, 3 menu objectives from a list of 6, and 6 clinical quality measures. And so stage three, it's actually not in effect. It becomes effective in 2016, but it focuses on improved outcomes. So now these are the three stages for the eligible hospitals and the CHAs, CHHs, CAHs, sorry, which mean critical access hospitals. These ones, they require 14 core objectives, so one more than EPs. Also, 5 menu objectives and 15 clinical quality measures. And then for stage two, as you can see right there, the criteria bumps up a little bit. So that's just a little brief overview about that. Now I'd like to dive into what specifically are these core measures and objectives that I am just previously talking about. So as you can see here, I have a list of all of the the ones for the eligible providers, the criteria. So for example, for lab results, EPs are required to incorporate lab results for more than 40% of their patients. That's one of the criteria that they must adhere to. Or also patient access, they must provide online access to health information for at least 10%. I'm sorry, that's for the menu objectives. Sorry about that. And then I found a study that was interesting that the three most common chosen menu objectives were drug formulary checks, immunization registry, data submission, and patient lists. You can take it for what it is. I just was a study that just said I don't know. I mean, they are the most commonly used, 84.9% of the time, 80.8 for the registry data submission, and 71.7% of the time they were picked for the patient lists. Just an interesting fact. Next, I'd like to move on to the clinical quality measures. So, like meaningful use and also performance measures, the definition I would say is basically the same. Clinical quality measures are tools that help measure and track the quality of healthcare services provided by eligible professionals or the hospitals and the CAHs within the healthcare system. So, for example, a CQM could be a health outcomes. That's a broad topic, and to go more into detail, they can focus on recording body mass index or smoking status. Um, and then also other broader categories of CQMs can be patient safety, the efficient use of healthcare resources, adherence to clinical guidelines. And these are just some of the things that organizations can record and use towards the incentive program. So now I want to move on to the incentive program payment amounts. Eligible providers who qualify, they're eligible for up to 44,000 per Medicare provider and then 63,000 per Medicaid provider. So the incentive program, companies or the providers are able to pick and choose whether they want to get the incentives through the provider or Medicaid, or they can get them through both. So another fact here is eligible hospitals are they can be eligible for up to 6.1 million in incentive payments over the course of the program. So that just shows you that there's a big chunk of money going towards this, but still at the same time not much when you take in factor how much money is going into other healthcare areas. So, but it is a decent amount of money that government hopes to get everyone to switch over towards these EHR reporting methods. So next, I'd like to talk about hardship exceptions. So the HITECH Act, which was responsible for the EHR incentive programs, spoke about how if providers were a part of the program but were not meeting the meaningful use criteria, that they would have to take a payment adjustment or deduction. So that this is for if they don't fulfill the requirements, as I stated, and company or providers that are part of the program are able to apply for a hardship exemption. So examples of exceptions or exemptions are if there are infrastructure issues which deal with like if a EP was in an area without sufficient internet access, that would cause them to not be able to perform at their highest level. They can use this and explain why they weren't able to meet the criteria. And also for unforeseen circumstances, so for example, a natural disaster, anything that hinders their performance, they're able to apply for an exception or exemption so that they do not have to take the payment deduction. So next I'd like to talk about the eligibility for the programs. So depending on who's applying, there are a ton of the eligibility really differs between who is applying. So CMS, which the Centers for Medicare and Medicaid Services, responsible for the program, their website, they have an online accessible eligibility tool that eligible providers can go in and fill out and see if they are eligible for one program or the other, or potentially both. So with that being said, I'd like to move on to the complications of the incentive program. Since it's a relatively new problem, there was going to be problems that were had, and there have been some that have arisen. So, for example, because performance measures are relatively broad, there is a lot of variability between the eligible providers and the hospitals, which makes it difficult to decide which performance measures of a healthcare organization are adequate and which ones do not meet the requirements. So there's a thought that if public and private payers were able to agree on a core set of performance measures, even so, that there still would be issues arising from transitioning from one core set to the other, and having providers buy into the new core measures. And then also, if the new core set of measures or the specifications for the measures are not as specific, there might be different interpretations, which would also lead to variability. Another complication that was found was a cross-sectional study done by Kern and Company, which compared the accuracy of electronic reporting to the manual review methods that are used at a lot of EPs and hospitals at this time. And it showed that electronic reporting overestimated and underestimated rates of recommended care by up to 40%, as opposed to manual reviews, which often did not. Other studies also have found that electronic reporting fails to capture evidence of appropriate care that is not documented in structured fields. So these structured fields would need to be picked up by a computer if they're not placed in the structured fields, or not correctly inputted into the system. They may be overlooked by the system. So that is a potential error. And so, with this being said, with these errors, it may cause eligible providers and hospitals to doubt the capability of this EHR reporting method, and if they are not positive about it and they don't trust it, they will be more likely to be hesitant about buying into it. As you can see here, other issues, a big one that came with the system was a lack of funding. And so originally the CDC developed a plan for up to 149 million in funding for public health IT infrastructure. However, now 30 mil, the great deal of it has been withdrawn and redirected away from the EHR systems, which causes a huge problem because then the money basically has to come from the organizations that are switching over. And then also a lack of time and resources, and then the inability of eligible providers to achieve meaningful use thresholds. Although with all these negatives, there are successes. East Alabama Medical Center's uses of performance measures, they do certain things. They do a thing called Behavior of the Month. What this is it's behaviors like just smiling around patients or communicating with the patients, just little things that can be done throughout the organization. This is what the controller of the medical center, Richard Byerly, basically put into effect. And in 1999, an interesting fact, this medical center was ranked below the 70th percentile on patient satisfaction, but since they've employed this behavior of the month tactics and others tactics, in a period of 2 years, they have increased patient satisfaction, and they've finished above the 95th percentile, so quite a big jump. But that is one instance, and I'm sure there are more. But there is a potential solution to help decrease the complications of the EHR incentive program. So cloud computing, it's just basically a model for enabling on-demand network access to a shared pool of configurable computing resources that can be rapidly changed and released with minimal management effort. So basically, examples are Google Documents, Facebook or LinkedIn, things that companies can access and work together and change things, so that they can find the best program available that's going to give them the greatest success. And what this also does, cloud computing, is they have the freedom from the infrastructure cost that are associated with anything outside of cloud computing. And then also the sharing of data across the users. That's a major deal, and a big thing that cloud computing helps with. So you may see this start to be incorporated more into these EHR incentive programs in the future. But for now, that's my presentation. And I hope you enjoyed it, and I hope you learned a lot. And these are my resources right here. And I appreciate you taking your time and listening. Thank you very much.